rollout with partnership with BDCFT and LYPFT, which explores the sensory experiences of autistic people on mental health inpatient wards and how they can be improved by staff. So next I'll explain the sensory checker training in more detail, and you can see an example screenshot on this slide. The YAMHEP team researched and completed sensory checker training after initial staff visits to our partnered Becklin wards. The initial ward visits allowed us to assess the ward environment without additional risk to the sensory checkers with lived experience, and training was given to Advinet staff members involved with the sensory inpatient project to ensure their understanding of our sensory checker assessment tool and explain sensory needs and experiences in detail. Our training also explains how our ward reports are structured and how the report utilises the sensory assessment data collected by them. The sensory checker training has been co-produced by autistic staff members with specific sensory needs and explores some of the sensory safety precautions such as ward maps and quiet spaces. I'll now hand over to Owen, who's going to explain our key project outcomes and the project's goals for the future. Thank you.
Thanks, Georgia. So yeah, as is evidence in the chat, the initial kind of impact and reception of the reports has been massively positive, and all the work in fact together, and people, some feedback is that the reports look great and people particularly like how accessible they are to read. I think it is important to say they're quite long reports, so kind of very much like looking at the finite detail, and like Freddie said, you know, it's really positive when looking at like long-term sustainable change, that everything is considered, and so people can kind of take what they want from that. So we have put in lots of detail overviews and that kind of thing like George has talked about. By building kind of this experience, we've had kind of new requests for training and sensory assessments. We've done one at Mind in Bradford, and kind of received one from shopping centres around sensory rooms and that kind of thing. And it's been a really good learning process for us in terms of we kind of knew quite a lot before we started this, but going into the detail of it's really helped, and having the funding to do that's really helped, and to create really good tools and stuff like George has been said. Becklin Centre in Leeds has kind of agreed to include a section about sensory needs in their reasonable adjustment questions when people are admitted to the mental health wards, which is a massive positive. Yeah, we've been collecting a lot of data, and I think, like hot off the press, I think we have actually identified an evaluator as of yesterday. But yeah, it should be an interesting read, that one. And like I said, there's a lot of appetite for kind of sensory related projects. I think it's entered the public consciousness as well as the professional consciousness, and we've done in Leeds some kind of sensory assessments for GP practices, some of the third sector organisations, and like Freddie said, there's kind of interest from lots of different wards. There's also kind of a national interest in this, and there's Georgie mentioned Jill Corbin, who works on the It's Not Rocket Science guidance, and I know some of our frustrations, a classic one is lighting, you know, kind of looking at national recommendations and guidance is a huge thing, so we'll be kind of using our learning from this to influence that national stuff as well. And yeah, finally, like Freddie said, hopefully we can get further funding for this, but till the kind of end of this project, we are going to do 4 more wards, like Freddie said, in Bradford, and we're following up kind of the reports and the recommendations and the next steps with the wards that we've done in Leeds, and yeah, looking kind of, like I say, to out a bit wider, because it's been a really important thing to start with the acute mental health wards, because I think that's where the greatest need is, but definitely looking out for future opportunities. And yeah, we kind of like working together, which has been really fruitful partnership in terms of training and that kind of thing, and definitely kind of like, you know, people's journey to mental health wards can often be prevented, and you know, a lot of that is around health access. So we've been linking that into some of the work we're doing as in the Bradford and Craven Autism AIM pilot project this year. And definitely we've done some learning. So like Georgia said, you know, kind of we developed a form to go through, but actually we've learned that sometimes it's easier to do things a bit more free form for some people, but we're constantly kind of looking at that and testing it after we've been towards and done some learning there. And yeah, that really, like I say, really great partnership, and got to give props to Freddie how much he's put in and the enthusiasm and the kind of thinking outside the box on this project. So it's been a really, really kind of fruitful partnership, working together, and definitely looking at those sensory maps is a really good kind of next step. And like Georgia said, like thinking about how to train more sensory checkers, and there are lots of considerations around sensory checking. I've said many a time that it's a bit like canary in the coal mine type thing, where you're putting people into an environment that we know is incredibly overloading and asking them to process that information. So it's not as simple as saying, go into a room and tell me what's overloading in this room. You know, there's people have different sensory needs and that kind of thing. So it's really important to think about that team and that kind of thing. And yeah, like Georgia said, kind of really being a bit sciencey about it and getting a sound engineer in to look at kind of where those sound tiles and to reduce that noise. I think it's fair to say that when you go through the wards, you can identify lots of things that needs to be changed, and it's frustrating, isn't it, Freddie, about the kind of how long things take to change sometimes. But there's some really, really massive easy win things as well, and a lot of the reports are kind of highlighting where maybe staff behavior can change. So it's quite you know, kind of like it doesn't necessarily cost money to do those kind of things, and it's as much about kind of making those changes than it is spreading awareness as well. So yeah, any questions? I've been seeing the chat popping off, and I said I would facilitate that. It's gone. It's really popped off, hasn't it, since we've been talking.
Do you have any help managing that, OM?
No. So I'm just catching up. So yeah. I think Freddie's covered, haven't you? That there's those kind of calm at night packs and the sensory suitcases, and yeah, it is a really positive project, and there's definitely massive scope, Rebecca, to roll this out in other places and spaces. Yeah, probably another meeting we need to have, Andy, about how we can link kids for the working leads. I'm just reading that one through. Yeah, I think it is really important to do detailed work, but like Freddie said, there's some kind of stuff isn't there that we've learned and that can be shared. I think it's as much engaging the staff, isn't it, Freddie, as well, like in that process, as they are busy. I don't know if you want to add to that. Yeah,
it's the bit of both, and because you want as many people to benefit from it as possible, but like you say, you don't want it to sort of be too tokenistic. So it's getting the balance right of what you can provide within the limits of what we've got at the minute. I saw some hands up. I've lost them on the screen, but people with hands up, if you just want to speak.
I think Janine was first, and then Andy.
Beautiful.
Okay, hi, just wanted to say they were great presentations about great projects, so thank you, and well done for those. Anything that helps promote awareness of sensory needs, particularly in hospitals, is really helpful, so thank you. But I did just want to point out that the mental health code of practice for the Mental Health Act says that autistic people inpatient care is rarely likely to be helpful because of all the issues that we've been talking about today, and should really be avoided. So it's just what is there potential within these projects for kind of flagging, if I appreciate, we're in an essentially dysfunctional health and care system where autistic people do end up in these environments, and we need to do something about that if they're there. But we also need to, the whole transforming care agenda is about, preventing admission, reducing the numbers of people in care and supporting discharge. So could this project, if people, particularly if someone's coming who's undiagnosed as autistic, and it's helping staff to sort of be aware of sensory needs and then flag that, and then supporting, what we want to do is get people out as quickly as possible if they do find themselves in inpatient care. So Owen, you mentioned work around prevention, but is there any way that it can link with that agenda as well?
So I think Andy might want to come in on that as part of the dynamic support register work, but I know as well, that there's a really good point.
Janine's introduced myself really nicely.
Yeah, you go on. Yeah.
So yeah, a bit of background about me. I'm the Transforming Care lead for autism in Leeds, and we have the community dynamic support register, but we also have oversight of patients within hospital. And ultimately, yes, you're right, Janine, that we try to keep as many people out of hospital as we can, but we do find that individuals with a diagnosis of autism have other mental health needs, and highly linked with psychosis, schizophrenia, which ultimately can result in hospital admission. And you mentioned about the undiagnosed population as well, which we're not being able to capture that great, and it only becomes apparent when they are an inpatient. So as a role of Transforming Care, we have oversight of those patients. And I think what my question was going to be, well, my offer was going to be, is linking in with yourself, Freddie and Owen, and looking at how we can promote this offer within our care and treatment reviews, the dynamic support register, so we can look at community sensory assessments and sensory environment assessments in the community, which might mitigate the risk of admission, but also working on the wards that haven't been captured and promoting your great work that you're doing already, and recommending that through our commissioner visits, what we hold on the wards every 8 weeks, if we've got concerns with the sensory environment, really. So yeah, that was the offer, and trying to build on it, really.
Yeah, I think the scope for building it is absolutely massive. It is that thing of there's so many places where there's need, and it is this thing of it interlinks with loads of different things. It's this thing of there's so many pieces of work going on, and half of it is coming to things like that and creating that connectivity about, oh, actually there's this work stream for that thing, there's this piece going on, because they do all ultimately connect, which hopefully there'll kind of be more of that happening as people become more aware. But it is just this thing of just to be real about the situation. Like I say, as far as we know, my role ends June, and I think Owen and Georgia, yours is March, so that's where we're at right now, which it's one of these things, isn't it? Obviously putting a business case together and all those kind of things that you need to do, but that's where we're at right now.
And who would that business case go to?
I think it's to the NHS England representative that we've got, and I think they've got in contact with the commissioning officer to kind of let them know that we're in the case of putting it together.
Right. Okay. Because I can be linked in with that as well, because I think it's very much needed. And from an ICB point of view, we can have those conversations as well and put that case forward, really. If that sounds all right.
Yeah, great.
More than all right.
More than all right, yeah.
Owen, did you want to respond to that before I?
No, I was going to verbally respond to Colette's.
Okay.
Yeah. So you go.
Yeah, I mean, as you know, I think it's a fantastic piece of work, and it's just brilliant, and it would be great to try and connect and widen this if we can. I unfortunately missed the meeting that you had with Mairead to look at the scope of this, so I need to kind of catch up with you about that and think about what the outcomes of that were and what we need to do. I don't know if she's asked you to present at the board or what else, just to think about. So you're going to get lots of place asks, but how can we make that efficient to share this information across West Yorkshire, without asking you guys to like spend a whole week going around and presenting it everywhere as well. So yeah, if we can get our heads together and think, but this is a great starting point, so people start to hear about the work, and lots of really positive comments in the chat. So well done, everybody.
And thank you all for listening.
Well, we've still got 11 minutes, really.
Yeah.
Yeah, I definitely. I know you've had some interest, haven't you, from Kirklees already as well. But definitely, yeah, like Freddie was saying, we want to look at the whole of West Yorkshire and get some parity there, because I think it's been really beneficial. And there are more wards in Bradford and Leeds, of course, but yeah, wherever we can spread the good practice is more. I guess picking up on an earlier point about like the people who are undiagnosed and people who are diagnosed, in fact, and actually what happens when they're discharged. And I think some of this work is really important in influencing that as well, especially as people often, more often now, are getting a diagnosis when they're in an acute mental health ward. Actually, their own sensory awareness, their own post-diagnostic kind of support is really important, and definitely influencing their kind of care plans when they leave, and their care coordination when they leave a mental health ward to prevent readmission. I think something we've missed off there as well is about the Autistica report, which said that the average stay for autistic people is 5.3 years. I think they've done a new one recently, which might be longer, but like, you know, that's a really massive scandal, because it's 28 days for non-autistic people. So yeah, definitely try not to, people not going into acute mental health wards is important, but keeping them out as well, getting them out and keeping them out is hugely important as well. Yeah. Is that a legacy hand, Shelley?
No, it's a new one.
Oh, it's a new one. Cool.
It was a question I had 5 minutes ago that I forgot, and then it's come back in my brain. So I know this was commissioned as part of the autism work and TCP stuff, but I think, Georgia, in your slides you mentioned, you know, ADHD and bipolar and other things, and obviously sensory affects everybody, and, you know, yes, neurodevelopmental conditions, but also most people in crisis. And I'm just wondering what you've developed. Do you both feel that that is quite adaptable for the general, you know, if you were going to take that onto an AE ward, it wouldn't really matter who's receiving that it would suit, you know, there wouldn't be anything that would be detrimental to somebody who wasn't autistic, sort of thing, you know? Does that make sense?
Yeah, I'll say something, and then Freddie, you might be better answering that one. I guess there's that sensory seeking thing, isn't there? So like, you know, kind of that adaptability is important, and it's difficult to manage that sometimes. And I think, like, you know, having a classic sensory room, and I know you've renamed them, Freddie, from a sensory room, like, can be a sensory overload room for lots of people, and obviously making those adaptable is important. But yeah, I don't know if you want to cover the other mental health conditions.
Yeah, definitely. I mean, for me, when I sort of picked up the project, you know, I was very keen that it didn't just focus on the autistic experience, but we tried to get everybody in with sensory processing issues, because it is this thing of the evidence base is there for schizophrenia, bipolar, trauma, PTSD, brain injury. You know, the range is massive, and they're all people on our wards. So when we did the pilot area, when we were developing the training videos, we kind of encompassed all of that into the training videos of, actually, these are some known associated conditions with it. You know, autism is very important in the experience, but don't just think that, you know, think a little bit wider. And in terms of the strategies, it's that thing of, really, when you're looking at sensory processing difficulty, it's that very individualized thing. So it's about getting the assessment right and talking to the person and going, actually, what is this? You know, obviously OT standardly will use a sensory profile, which is more around modulation. But then if actually someone's got more of an actually sensory integration issue, you know, are we needing to get specialist people in, you know, the sensory integration trained people? And that's the kind of difference, and something I've been kind of keen very much to spread the message off is, where do people's roles sit within it? Because everyone's got a role in sensory awareness. For me, that's very much absolutely everybody should be aware. And then it's about, well, once you know that, do you know where to go to if you've got a suspicion about something more complex or in depth? And all the tools we've kind of developed have been off the evidence base for sensory processing. issues in general. But yeah, I just think that individualized thing has to be the thing of you can have a template, but you then have to be able to, you know, have that relational thing with people. Georgia, you've got your hand up. Chip in.
Yeah, I was also just going to add that I think it's important that people consider as well, not just service users in terms of the wide range of sensory needs, but also staff, because a lot of the recommendations that are made and also the changes that Freddie is implementing, these will help also neurodivergent staff with specific sensory needs. And it'll probably make the co-regulation as well that I mentioned in the presentation better. So hopefully it'll improve outcomes across the board, not just for service users, but also staff as well.
Yeah, I think that's something we've both been quite mindful of, haven't we, when we've been doing it as well, is you know, making it accessible to everyone. So at the pilot site, we kind of encourage staff to model the use of the tools as well, because it's that thing of, you know, if other people see you doing it and know that it's okay, then, you know, it becomes kind of a more normalized and accessible thing for people. And then, yeah, with the sensory spaces, I do have this slight thing about the overuse of the word sensory, and it always is a bit of word games. You know, there's always going to be discussions around what's the right terminology for things and stuff. But I labelled the room and make it your own space, because I think it's really important that we actually, that's the message we're getting across people. It's not always about sensory, it's about being able to make a space right for you, whatever that is. Yeah, and I think that's been quite helpful in reframing it for people, because people sort of came in and they were like, it's really bare. And I was like, yeah, but you could get this out and do this if you wanted, but you know, you don't have to.
I think that was an interesting discussion, wasn't it, on the forensic ward, was around like, you know, where patients can purchase their own things. That's a slightly easier process than going through estates and all that and finance stuff. And but actually, that's a really positive thing to encourage them to be able to self-regulate in their rooms as well. And having the make it my own space room, like, you know, can hopefully educate them a bit on that and see what works for them. And they might go, I'll have one of them in my room.
Yeah, that's it. Try before you buy.
Yeah.
Thank you. I think that's really helpful, and like you say, if you can make some provision that benefits the majority of people, then that's a win. So fantastic. There's a couple more points in the chat, but I don't think necessarily questions, unless I've missed any.
No, just lots of lovely feedback and yeah.
So what we will do, if Freddie, you could share your slides with me and Georgia, and what we'll do is we'll put them onto the NHS Futures platform with the recording, and people can access them, and then people can contact you directly. But we will try and think about how to get the message out in a kind of most efficient way, really. And I'm wondering whether the board or the steering group, because each place is represented, whether that's a good place to then look at how Leeds want to kind of do that and take the learning. But really grateful for coming, and thank you for sharing that great work.
Thanks for having us.
Thank you.
Thank you. Okay, right, everybody's got an extra 3 minutes. That's a bit unheard of, isn't it? Use it wisely. Thanks everybody for attending, and we will see you next month.
Thank you.
Thank you.
Bye.
Cheers.
Thanks everybody.
Thank you. Bye.
See ya.